Thank you. Thank you. Can you all hear me? I think so. Yeah. Okay. So, first of all, to talk about what the service actually provides, is the Center for Interventional Pediatric Psychopharmacology and Rare Diseases. We have 3 streams of patients we see. The first stream of patients are those who we've just got some neat things to just talk about what the philosophy of the clinic is. Clear, complete care and research is what we're supposed to be doing. The first group of patients are those who are admitted into inpatient settings and who are not responding after 6 months or more. And these are patients who NHS England usually contacts us and asks us for help. So those are the patients we see. We often go into the organization wherever they're admitted. We assess them, and we actually change treatment plans, and we try and get them out of hospital as soon as we can. And we've been quite successful in that. And most of these patients, unfortunately, are patients who've got multi-comorbidity and often associated with autism-related and other conditions, who've been admitted for psychotic or other conditions and are non-responders, which is in keeping with what I think was also discussed previously by another speaker. The second group of patients are those who've got multiple comorbidities. So these are patients who usually have 5 to 6 conditions at the same time, axis 1. So we're talking about ADHD, ASD, ODD, catatonic, psychotic, depressed, and anxious. They're the sort of kinds of patients we end up seeing. And these patients we are usually sent through to us when they've already failed 2 or 3 treatments and at least been seen by 2 or 3 specialists. So those group of patients come to us, and then we usually assess them, manage them for a year, try and transfer them back into the local service. And the third group of patients are patients with rare diseases. And here we've got 3 sort of groups of patients we see. One is a group of patients who've got genetic conditions like Rett syndrome, Sanfilippo disease, and Niemann-Pick type C and other conditions as such. Second group of patients are those who've got acquired brain injury. So these are patients who were normal, ended up with usually a head injury, or probably after anesthetic complications and so on. And so they've ended up with traumatic brain injury. So that's the second group of patients. And the third group of patients we see are patients who've ended up with quite severe, rare side effects to psychotropic agents. So these are patients who've developed clozapine-induced pericarditis, or who've ended up with significant neutropenia, and then someone's used lithium, ended up with a blast crisis, therefore then referred to us to be able to manage them, and conditions like that, tardive dyskinesia and so on. And then, so the reason I'm going into this is that research-wise, what we've decided is that because the kinds of patients we see, if we look at the group of patients with multi-comorbidity, it's sort of the group of patients whom we could consider as being those who've been born with wrongly wired brains. The group of patients who are with acquired brain injury, who did not have psychopathology before, so they had normally functioning brains, and then because of traumatic brain injury, whatever it is, they've ended up with a damaged brain subsequently. And then we've also got access to patients who got neurodegeneration. These are childhood dementias. So these are patients whose brains actually progressively getting worse. So what we've got is a unique group of patients where we can see what happens when molecules pharmacology is used in these 3 different groups of patients. And that's exactly what we've done. And not just pharmacology, psychological interventions too. So we've got an understanding as to what might be needed in these different kinds of populations, which has been the focus of our research right through. So when we've been looking at all of these patients coming to the clinic, as you can see, this is not a group of patients whom we can classify just by diagnosis because they're very, very varied. But when we've been studying, what has been really striking is that it does not matter which group of patients we're seeing, we end up with this particular group of symptoms, that is emotional, behavioral, autonomic dysregulation. And these are patients who've got mood lability, easily irritable, hyperactive, rushing around, aggressive, but the one component that has not been looked at properly in psychiatry is the autonomic component. And so what we ended up doing is we've broadly called this EBAD, or Emotional Behavioral Autonomic Dysregulation, and have been looking at trying to objectively measure EBAD in all the patients coming through, and we've now got information in around 500 subjects using wearable technology and so on, which I'll just talk about in a minute. And so what is very clear is that unless EBAD is actually more looked at, assessed, and treated, it's very likely you're going to end up with treatment resistance. And if you look at what Andrea just spoke about in terms of maltreatment and the sympathetic thing as such, consequences and poor outcomes, you can see exactly where the autonomic component could actually be fitting in. It's not about why it's happening, it's the fact that it's present. Unless you treat it, it's very unlikely that you'll actually get response to your typical treatment strategies. So in terms of how the clinic functions, what we've got is we've got an assessment and treatment process where we get referrals, we accept it, there are sent web-based questionnaires to do online using the system called Health Tracker, and then after that we assess them, and then we actually conduct an audio conference as such, because 95% of the patients are not coming to us from SLAM. They are from outside. So they're patients from all over the country. And so we actually use a very simple business conference call scenario where we call the mother, we call the father, we call the child, we call the teacher, we call the GP, we host the call, and it's free for all the people, but then we can actually get a lot of the information that is necessary to decide what we need to be doing when they come into the clinic. We then get the medical and the physiological assessment done when they come into the clinic, and we also decide about the neuropsychological assessments needed. When they come into the clinic, usually because we've got so much information already, we can make a definitive diagnosis within 2 hours or so when they come in. And these are patients traveling quite a long way coming in, which then means that we can actually talk about what the possibilities of what are the comorbid diagnoses they have and what treatment strategies are possible. We provide them with information leaflets which are adapted for patients as well as for parents, and then we ask them to wait for at least 24 to 48 hours before they decide as to what treatment they'd be opting into. Usually they're given at least 3 to 4 treatment options to consider, and we give them the pros and cons for each of them. Once they've decided, they go into the medication stabilization monitoring clinic, which is an entirely telephone-based service. So they do not need to come into the clinic. We phone them, and it's usually a 5 to 10 minute phone call to check and see whether once they've started the treatment, whether they've developed any side effects or not, and then we use a particular strategy we've developed in the clinic, which allows us to get information in a very systematic manner about medication strategies, which then allows us to look at it in the group data sense. So here then post-treatment we get physiological as well as information prompts from multiple sources. And then once if there are any emergencies, then of course we get them into the system quickly. So this is the strategy pharmacologically that we've actually emphasized in the clinic, and this is what we do for every patient coming into the service. It does not matter whom. So what we do is we do a functional analysis of the problem behavior. We take the underlying cause into account and then decide whether there's a pharmacological treatment necessary or not. When we start treatment, we usually start with roughly 1/6 to 1/8 of the dosage that we think might be needed. This is because of the fact that, and then we increase it by every 5 to 8 half-lives of the drug. So in psychiatry, if it's a short-acting drug, it's increasing it every 3 days. Long-acting drug, we usually increase it roughly once in 7 days. And by doing this, what we do is that we start, let's say it's fluoxetine. We usually start them on either 2 milligram or 4 milligram. We increase it every weekly, but we actually give them a phone call and find out from them whether they've developed any side effects, acute side effects, and whether they needed to consider whether they'd be happy to go on to the next dosage. And so usually what happens is that if there's a side effect, we ask them to stop the increase, and then we actually ask them to go to the previous dose. This whole procedure is not just to do with pharmacology. What this means is that I often call it the art of prescribing. The reason is that because the parents and patients have opted into treatment, what happens is that they feel that they're committed to the whole thing. We have exceptionally good compliance. We have over 95% of patients being on medication even after 3 years on the population we continue to follow. And the problem we have is trying to stop them from continuing medicines rather than the other way around. So our view is that this whole process allows to increase the placebo effect of the drug by actually increasing the therapeutic alliance, and also, of course, the pharmacological thing, because we are reducing side effects by using low doses. So if you can understand, the mean fluoxetine dosage in the clinic is around 8 milligram in these most difficult kids, which would be completely unheard of when it comes to typical strategies where you'd start with 20. So coming to how we can use technology into this whole thing, because our focus has been on EBAD, and so here what we do is that we get all the information here, and then we've got the physiological data being monitored. So every child coming into the clinic, whilst they're in the waiting area, they actually get the watch worn, and then they wait there for 10 minutes, so we know what's happening prior to the coming into the clinic. The clinic is structured in 10-minute blocks, where we actually have neutral topics in the beginning, talk about very difficult topics, and then after that, once they've actually come into to the end of the thing, we leave them in the room for a further 10 minutes to see whether the stress decelerates or not. So it's a standard procedure for everyone. And then we also get information about medication side effects, the neuropsychiatric profile, and treatment response systematically for everyone. So when it comes to, and we don't focus on, and increasingly we've come to realize that our real outcome measure should be participation in the group of patients we see, and not just quality of life, because you can have quality of life being shown to be increased, but they really are not able to participate in things that they should. So our focus now has moved from being just symptoms to starting to look at symptoms, relationship, participation, which is where I think this whole exciting stage of looking at technology and how we can get there. So this is the scale that we often use. This is called the Profile of Neuropsychiatric Symptoms, which has been published and validated. It gives us the symptoms here, which are neurodevelopmental. This is to do with psychosis and other symptoms. This is the behavioral and emotional dysregulation, and this is the anxiety and depression symptoms. And what we do is that we monitor these domains across all categories of patients, and we actually treat each of them depending on need. So this would give you a typical thing when it's longitudinally looking at, and where you can actually get at the symptoms which are there, derived from that, and see what's actually changing across time, and you can actually get and you can get it from multiple sources, so you can see what's happening from the teacher, parent, and so on. So this is probably the most important part of the monitoring in a systematic manner, is that if you're starting to treat ADHD and you've started using methylphenidate, you typically would be expecting and monitoring ADHD symptoms, and you'd be trying to reduce hyperactivity in attention and impulsivity. So what happens is that this is what typically happens with methylphenidate, at least in the kids we see in the clinic. This would actually be quite good, but this is also what happens. And what you really, and this is in a particular patient. I'm not generalizing it to every patient. This is a patient. So for this particular patient, methylphenidate is probably not the most useful molecule, because it's multi-comorbidity that we're talking about. And so when we use aripiprazole, this is what happens, and this is the total difference that we actually get. And we're just talking about 2.5 milligram aripiprazole, and you get reasonable outcomes. So the clinicians do a scale once every 3 months or so, which takes them roughly 10 minutes to do for a patient. And what it comes out with is the treatments that have been used till date. You'll actually be able to know whether there is improvement, minimal improvement, moderate improvement, marked improvement, or side effects this way, where this is significant side effects. So the problem is that if the patient is in any of these red boxes, the medicine should be stopped or altered, and then you actually try to get them into the green boxes. And this is what the system would automatically review. And so you have on a single screen, you're able to see what the medication outcomes for this particular patient, this is the life history of the patient in terms of treatment. This allows you to reduce, improve the outcomes and reduce risk for patients. So coming to the wearable technology, what we have, the sensors can pick up electrodermal activity, the heart rate variability, accelerometer data, and so on. This is to show what happened in one particular patient where, with Rett syndrome, whom we had started on buspirone to manage the panic disorder, and while we were monitoring, the blue was what it was at baseline, and the red was post-treatment. And what you can see is that there was a sudden worsening of the electrodermal activity, and the patient was sitting in the wheelchair in the clinic, and we really didn't know what was happening, because the parents said the child still seemed to be restless and slightly anxious, but we didn't know what was it. 2 days after this was done, the patient was in intensive care because the patient had undetected septicemia, and was actually, so this is because the patient was not able to communicate everything. So it actually allows us to track information in especially children who do not have the ability to communicate. This is the last slide to say that when we are monitoring patients here, this is a patient who's got all of these conditions and was stable on multiple medicines because he was very difficult. This is when he was stable, and you can see the data which is to do whether it's heart rate or electrodermal activity. And then you've got this when he relapsed, and this when he's starting to improve again. And so now that we've got data of around 500 patients or so, systematically done with all the information about medication, other treatment strategies, plus physiological data, multiple time points, we are able to start looking at machine learning strategies, which then allows us to actually start looking at clusters and predicting what might happen to a particular treatment if we were to initiate it in a particular child. And we've already started doing that for EBAD subgroup, and on an average, the duration that we've been able to cut short for control of symptoms or improvement in symptoms has been 4 months. And that's, I think, quite significant when we're talking about an extremely complicated group of patients who are coming to us from all over the country. This is to just acknowledge the team, without whom I wouldn't be in a position to present anything like this, because this is a very difficult group of patients, but we've got the luxury of having the clinical team as well as the research team together, who, the important thing is that all that the clinical research team does is translational and can be moved into the clinic almost immediately, and that has been our most important asset in the team. Thank you.